here with the Harry Barnes Society and being able to talk about some important issues with vocal health. And so on behalf of Dr. Alexander, as you know, she's dealing with the airway emergency in the laryngology fashion. We'll just talk about World Voice Day. So she just asked for me to touch on these slides today. So World Voice Day, this year, every year there's a new theme. And it's sponsored by Academy of Otolaryngology. And so this year's theme is One World, Many Voices. And it's celebrated typically, you know, the second or third week of April, with the date being set for this year, Friday, April 16th. And with the pandemic, there's going to be a lot of virtual events going on from many academic institutions. And the main goal is to encourage good voice health across lifespans. So you want to take action to establish and improve health habits in regards to vocal hygiene. And this really began in 2002 with the inaugural celebration of World Voice. And it's not something that is really mutually exclusive for professional singers or anything like that. It just really emphasizes the importance of voice as an expression of who we are individually. So top 10 tips on vocal hygiene for everyone, especially now in the virtual age of, you know, significant voice use in Zoom meetings and the like. Everybody is in essence a professional voice user right now. So we're noticing a lot of vocal fatigue, and here are some ways that we can mitigate that. So you want to stay hydrated. So try and stay away from caffeines. And this is important for our patients as well. So avoiding caffeines, any high fructose corn syrup beverages, carbonation, exacerbate reflux as well as dry you out. You want to add a glass of water for each beverage that is listed above to counterbalance those diuretic effects. You want to avoid inhalants. We all know tobacco is really bad for a variety of reasons, and also other inhaled irritants, just chemical, you know, cleaners and things as such. You want to keep clear of URIs, make sure that you're, you know, in the setting of COVID, we're staying masked up, we're washing our hands frequently, keeping our hands away from our faces. You want to make sure your medications aren't exacerbating any type of dysphonic issues that we may be having. So antihistamines are drying, diuretics are also drying, antihistamines with D or pseudoephedrine, particularly drying. So if you can avoid those as best as possible, then that will be great for your voice as well. Be moderate with your alcohol. It's a disinhibitor, so that's going to encourage you to be a little bit more louder and belligerent than usual, and risk of vocal damage. And it's also a dehydrator as well. Watch your meals. You want to keep fat and sugar to a minimum, and you also want to stay away from food around 2 to 3 hours before your bedtime or before laying flat, period, to avoid any significant reflux. Sorry, I've just developed allergies moving to Memphis, so my sound congested. I'm not a good advocate for these top 10 voice tips right now with my nasal voice, but you want to keep your friends close, avoid shouting as much as possible. You want to try and stay away from whispering. Whispering is actually phonotraumatic and could cause your whatever dysphonic issues to be exacerbated. So just avoid whispering. And you want to listen to your body. If you're having a long day where you're having a lot of vocal fatigue and your endurance is low and you're maybe having some symptomatic cervical tenderness, then you want to ensure that you are giving your body the appropriate rest that it needs. So listen to your voice. And if you do have any voice changes that last more than 2 weeks, that's not associated with the URI, then you want to make sure that you get assessed adequately, particularly if you have risk factors such as smoking. So that is Dr. Alexander's top 10 tips for vocal hygiene. And so now I'd like to welcome Dr. Yolanda to start our discussion on vocal fold paralysis, and we'll be talking about diagnosis, management, and treatment. Let me give you the screen. Okay, perfect.
Hi, I am Yolanda Himanaka. I am a laryngologist. I specialize in professional voice care. I am at the University of Texas Medical Branch in Galveston, And today Sandra and I are going to share a presentation on vocal fold paralysis. I'm going to talk about the differential diagnosis and evaluation, and then she's going to talk about the treatment algorithm. So our primary goals when we see a patient with vocal fold paralysis are twofold. The first is to diagnose and treat any of the etiologic or contributing factors that led to the vocal fold paralysis. And this is one thing that we really can't forget to do. And the second is to treat the morbidities related to the vocal fold paralysis, the dysphonia, the dysphagia, and the dyspnea if it exists. So the common controversies related to vocal fold paralysis include where is the site of lesion? Is it the recurrent laryngeal nerve? Is it the superior laryngeal nerve? Unilateral or bilateral? Are both nerves involved? What's the cause of the paralysis? What was the onset? And what are the disabilities related to it? And then when you're looking at the treatment algorithm, you're also wanting to know whether or not the paralysis is improving, worsening, or plateauing, and whether or not there are any comorbidities related to the patient, and that may affect your choice of treatment or the timing of your treatment. So when we think about site of lesion, we really want to know which nerve is affected, because that primarily affects how we approach the treatment management. Is it the recurrent laryngeal nerve, which causes both abnormalities in both abduction and adduction of the affected vocal fold? Usually the ability to stretch the vocal fold to raise the pitch of the voice is not affected with recurrent laryngeal nerve, isolated recurrent laryngeal nerve injury. With a superior laryngeal nerve injury, adduction is affected, as well as the ability to stretch the vocal fold to raise the pitch of the voice. But commonly, abduction is unaffected. And then when you have injuries that involve both nerves on the same side, all three are affected. When there's an issue with the cricoarytenoid joint, it can cause an immobile or hypomobile vocal fold, which can cause some signs of which will show muscular effort, but an immobile vocal fold. With the delocation or dislocation of the vocal fold, the key issue is an abnormal height of the vocal fold. So, when we look at which nerves control which muscle actions, your superior laryngeal nerve is the nerve that's going to control your cricothyroid muscle. And when the cricothyroid muscle contracts, it pulls the cricoid cartilage up to the thyroid cartilage. And as the cricoid cartilage is pulled upwards, the arytenoid cartilage falls posteriorly, and that stretches the vocal fold to increase the pitch of the voice. And the superior laryngeal nerve is the only nerve that affects the cricothyroid muscle itself. The recurrent laryngeal nerve itself innervates the other four muscles in the larynx. The posterior cricoarytenoid muscle, which when it contracts, it abducts the vocal folds or pulls them apart by rotating the vocal process of the arytenoid laterally so that the vocal folds open. It also affects the vocalis muscle, the interarytenoid muscle, and the lateral cricoarytenoid muscle, which when they contract, they rotate the vocal process of the arytenoid medially so that the vocal folds close. The thyroarytenoid muscle, when it contracts, it tenses the vocal fold and then it shortens it, and that also causes the vocal fold to close. So when we look at a patient who has a unilateral recurrent laryngeal nerve paralysis, but a normal superior laryngeal nerve function, a relatively normal superior laryngeal nerve function, one thing you want to notice is that the length of the vocal fold from front to back or anterior to posterior is relatively symmetric on both sides. And the ability to raise the pitch of the voice by stretching this muscle on this side is equivalent. When you have a person who has a unilateral vocal fold paralysis, one of the other things you're going to notice is that the cricoarytenoid joint, which is here, should be mobile, so that when the uninvolved side opens and closes, that arytenoid cartilage hits the arytenoid cartilage on the involved side. And you should see what we call a jostle sign, which is the little bumping of the arytenoid out into the piriform sinus as it is hit by the other side. So this is that jostle sign we were talking about. With an arytenoid, a cricoarytenoid joint fixation, usually you don't see that bumping of this cartilage when the other side hits against it. When a patient has a recurrent and superior laryngeal nerve paralysis on the same side, one of the things you're going to notice is that the vocal fold on the involved side is shorter than the other side because it cannot tense from action of the superior laryngeal nerve. So with an arytenoid dislocation, you can have an immobile or hypomobile vocal fold. One of the key issues with this is you're going to see the thyroarytenoid muscles and the false vocal fold tissues in here trying to move as the patient is talking or trying to adduct and abduct their vocal fold. But with an arytenoid, an anterior dislocation, usually the vocal process is going to fall anteriorly, which is going to bring the height of the vocal fold on the involved side to a lower place than on the uninvolved side. With a posterior arytenoid dislocation, the arytenoid falls posteriorly. When it falls posteriorly, the vocal process tilts upward and the vocal fold looks as though it's at a higher height than the uninvolved side. Now, when we think about what could be causing the vocal fold paralysis, we have to remember the course of the laryngeal nerve. It starts at the skull base, extends down with the vagus nerve. The superior laryngeal nerve has an internal and external branch. The first branch goes into the cricothyroid membrane where it provides sensation to the superior larynx or the supraglottic larynx. The other branch goes down to the cricothyroid muscle where it helps to tense the vocal folds. The recurrent laryngeal nerve continues to travel down on the right side. It'll travel down, it'll loop underneath the subclavian artery and then come up to the larynx just posterior to the cricothyroid joint articulation. It can travel either within the tracheoesophageal groove or just lateral to it on the right side. On the left side, when the recurrent laryngeal nerve leaves the superior laryngeal nerve, it goes down into the chest, loops underneath the aortic arch, and then comes up inside the tracheoesophageal groove to the larynx at the cricothyroid joint articulation. So what does the site of lesion tell you? Well, when you have a recurrent laryngeal nerve paralysis alone, one of the things that you learn is that the site of lesion should be below the level of the thyroid membrane because that's where the recurrent has left the superior laryngeal nerve. And it can be possibly as low as the mediastinum on the left side or the subclavian artery on the right side. Both your physical examination and your laryngeal EMG will help you with determining which nerves are involved and where your site of lesion is. With a immobile vocal fold, usually you're not going to have just an isolated superior laryngeal nerve paralysis. Usually a superior laryngeal nerve paralysis causes a hypomobile vocal fold, but not an immobile vocal fold. But if you have an isolated superior laryngeal lesion, usually the lesion is going to be somewhere between the thyroid membrane and the cricothyroid membrane. And typically this is an inflammatory lesion caused either by thyroiditis, a post-viral neuritis, Lyme disease, and now in the COVID era, you can get a post-COVID neuritis also. If both the superior and the recurrent laryngeal nerves are involved, the lesion can be anywhere from the skull base to the mediastinum on the left and the skull base to the subclavian artery on the right side. We talked about the height of the vocal process with the arytenoid dislocations. If the vocal process is at a normal level, one of the things you want to think about is whether or not there's scarring in the cricoarytenoid joint itself and the subglottic area that's tethering the vocal process or the arytenoid itself, keeping it from moving, or whether or not there's scarring between the arytenoids. Mechanism of injury. So when you have somebody who's had either surgery or trauma and the vocal fold paralysis immediately follows that event, and if you wanted to start thinking about what could have caused it and where the likely source of lesion is. There was a time when thyroid surgery was the most common cause of vocal fold paralysis. Because a lot of people are using nerve integrity monitors, thyroid surgery has gone down on the list in terms of being the most common cause of unilateral vocal fold paralysis. It still is the most common cause of bilateral vocal fold paralysis, though. With unilateral paralysis, cardiothoracic surgery now is the most common cause of iatrogenic vocal fold paralysis, probably because with the robotics, people are doing more aggressive cardiothoracic surgery. Um, Anything can happen during surgery. If you have a crush injury, cautery, or transection of the nerve. The intubation itself can be traumatic and can cause either nerve injury or cricoarytenoid joint dislocation. Sometimes even with upper endoscopies, you can have issues with um, vocal fold or cricoarytenoid joint dislocation. Any kind of neck surgery, including thyroid surgery, carotid artery dissection, anterior cervical fusions can cause issues with vocal fold paralysis. Prolonged intubation, meaning intubation for anything longer than 100 hours, can cause a vocal fold paralysis, either from pressure from the balloon, having an overly aggressive pressure in the balloon itself, or just having a balloon that's been in place for, like I said, 100 hours or more can cause vocal fold paralysis. Um, Having the tube sit posteriorly, having a tube that's too big for the individual. Ideally, a female really shouldn't need a tube greater than a 7 millimeter inner diameter, and a male really shouldn't need a tube greater than an 8 millimeter inner diameter. The larger tubes that are sometimes used in cardiothoracic surgery tend to cause more just pressure on the trachea itself. There are perforators from the recurrent laryngeal nerve that enter into the trachea, and you can get direct injury from those perforating branches of the recurrent laryngeal nerve. Brain surgery in the motor cortex, particularly deep brain stimulation, can cause bilateral vocal paralysis or pseudobulbar palsy. Whenever you see sudden onset of bilateral vocal paralysis that's not related to brain surgery, you want to think about a CNS lesion within the motor cortex or anywhere along the, the cortex line of exit from the brainstem. Penetrating trauma, meaning gunshot wounds, knife wounds, stab wounds, can cause vocal fold paralysis, and then blunt trauma. Non-traumatic causes of vocal fold paralysis can be inflammatory, including post-viral syndromes, Lyme disease, syphilis. Autoimmune diseases can both cause vasculitis that affects the nerves itself, or they can cause pressure effects on the nerve or within the nerve. Sarcoidosis and amyloidosis can cause issues with paralysis of the vocal fold, both from lesional effects as well as from effects within the nerve and nerve sheath itself. Thyroiditis, both Graves' disease, Hashimoto's, lymphocytic thyroiditis, and even post-infectious thyroiditis can cause both sudden onset and gradual onset of vocal paralysis. Patients who have diabetes and peripheral neuropathy related to it can get a neuropathy in their laryngeal nerves. Patients who have uncontrolled thyroid disease, hypothyroidism, or even hyperthyroidism can get a sudden onset of vocal paralysis that will reverse when you treat the underlying metabolic issue in the thyroid. Same thing with vitamin D deficiency and other electrolyte imbalances. Malignancies can cause direct effects on the nerve through pressure and encase the nerve. And the structural lesions can also cause issues with pressure on the nerves. Thoracic or aortic aneurysms, carotid dissections, sometimes cervical osteophytes that are sitting just at the right location that the where the cricothyroid joint space is, can cause issues. Esophageal diverticula, enlarged thyroids, and even tracheal diverticula. Usually when you see a patient with an acute presentation where the onset of their paralysis is less than 6 weeks, A trial of steroids and antivirals is indicated, even if the tumor is the issue. If you can try to get the inflammation around the nerve sheath down initially, it will help with regeneration of the nerve and with recovery. Usually a high dose of steroids, meaning 60 milligrams of prednisone a day for 2 weeks, and antivirals, something like Valtrex, also for 2 weeks, will help with improving the outcome in terms of recovery of nerve function. And with sudden onset vocal paralysis, you want to consider what the acute inflammatory causes are, whether or not there's any signs of trauma or a history of trauma, and whether or not there could be a malignancy. Gradual onset vocal paralysis oftentimes is caused either by tumor or malignancy, sometimes by structural issues that are causing pressure on the nerve, and sometimes even chronic inflammatory causes. Symptoms that patients will have or may have: dysphonia, which commonly manifests as a breathy voice, a soft voice, vocal fatigue. When they're having problems with swallowing, they complain of choking or coughing when they drink or eat. Um, and dyspnea. Oftentimes, dyspnea is not a feature of unilateral vocal paralysis. It's usually a sign of bilateral disease. And when you do see bilateral disease, you want to think about a CNS lesion if they haven't had recent surgery or trauma. So, what kind of laboratory testing is indicated, not indicated? Do most people do, not do? There isn't a lot of really scientific studies that tell us what makes sense and what doesn't make sense. There's a lot of anecdotal evidence for what people do. We have seen that people who have acute onset of vocal paralysis and they get some of these laboratory testings, that some of the test results turn positive. Sometimes I've seen Lyme disease, where we treat the Lyme disease and the paralysis gets better. I've seen patients have a positive FTA-ABS and we treat them for syphilis, and the vocal paralysis gets better. So there's definitely anecdotal evidence that getting some of this laboratory testing makes sense, and that patients, when treated with some of these diseases in the face of paralysis, that they will have an improvement in symptoms. But there isn't any hard science that says that doing any of this really from a level 1 study type perspective has ever been shown. But the things that people write about are when they've had a recent viral upper respiratory infection, within 4 to 6 weeks of onset of their vocal fold symptoms, most people would consider that a post-viral neuritis or post-viral vocal fold paralysis and treat them with the steroids and the antivirals. In the age of COVID, it probably makes sense now to get a viral respiratory panel, both to make sure that they don't have COVID, and then also just to look for whatever viruses, influenza, parainfluenza, or any of the other coronaviruses that could be causing their illness. A Lyme titer is commonly ordered. FTA-ABS, looking for autoimmune disease. Typically, I'll do an ANA and a SED rate. If I think they have sarcoid, I'll check the ACE level. If there's other reasons on the exam for me to think that scleroderma or Sjogren's may be an issue, usually I'll check an SSA or an SSB. If they have other signs of Wegener's or any other vasculitis, usually I'll check a myeloperoxidase antibody, C-reactive protein, and an ANCA profile. If they show signs of Graves' disease or hyperthyroidism, I'll check a thyroid binding inhibitory antibody, a thyroid stimulating antibody, and or a thyroid receptor antibody, just to make sure that Graves is not an issue. In almost all my patients, I'll check the thyroid peroxidase antibody because the subclinical Hashimoto's I find is very commonly associated with sudden onset or gradual onset vocal paresis and paralysis. Usually I'll test for diabetes, I'll test for their TSH and free T4, look at the vitamin D level, because all of these can be subclinical also and present only with vocal paralysis as the initial sign of their disease. Sometimes I'll check for myasthenia if they have signs of fluctuating paralysis with a acetylcholine receptor antibody. Then you want to think about imaging. I think that for everybody who has a vocal fold paralysis looking for malignancy, definitely is indicated. The three ways to do that are CT scan of the neck, MRI scan of the neck, and thyroid ultrasound. CT scan, usually want to get a high resolution scan with cuts that are no thicker than 2 or 3 millimeters. Sometimes if you get a 5 millimeter cut study, it can miss subtle lesions especially. The advantage of the CAT scan is that it gives you good imaging of the cricothyroid joint. So if you're thinking that there might be an arytenoid dislocation or recent trauma, the CT scan is a good scan to get. And usually want to get 1 millimeter cuts through the larynx itself. It also gets good imaging of the mediastinum. For patients who are claustrophobic, who have difficulty lying still, where you don't think getting an MRI is going to be feasible for them, the CAT scan is a good alternative. The disadvantage of the CAT scan is that it doesn't image the skull base well, and it usually doesn't image the thyroid well. So when you think that there might be issues with the skull base, meaning they have both a superior and a recurrent laryngeal nerve issue, or that there might be some issues going on in the thyroid, the CT is probably not the study that you want to start off with. The MRI scan, same thing, you want to do an image from the skull base through the mediastinum. You want a high resolution study with cuts, again, no larger than 3 millimeters. It's nice because you can get a good three-dimensional imaging of the airway and the neck. It has a better imaging of the skull base than the CT scan does, and gives you reasonable imaging of the thyroid, even though the ultrasound is going to be your gold standard for imaging the thyroid itself. The disadvantage, obviously, is that patients are intolerant to lying still. It doesn't image the mediastinum as well as the CT does, and it really doesn't give you an indication of what's going on in the cricothyroid joint. So if you're thinking that there may be a cricothyroid joint issue, CT scan is going to be your better study. If you're thinking there's a skull base issue, your MRI is going to be your better study. If you're thinking there's something going on in the mediastinum, your CT scan is going to be your better study. You ask 100 laryngologists, 50 will tell you CT scan first, 50 will tell you MRI first. I don't think that there really is any consensus on which one to do first. And all the studies that have looked at whether or not it makes a difference have shown that there really is no diagnostic information that you don't get from one or the other, except that the MRI is better at imaging the skull base. So when you do laryngeal electromyography, most laryngologists would recommend doing laryngeal EMG in everybody who has a vocal fold paralysis, whether it's iatrogenic or not, it's idiopathic, there's a tumor or lesion, because it gives you some good prognostic information about what's going on with the nerve. It can help you sort out which nerves are involved. Sometimes when we do examinations, we see one thing, some of the muscles in the larynx initially will overcompensate for the lesion that's going on. So you may miss the subtle superior or recurrent laryngeal nerve creases or paralysis that's happening in conjunction with the main motor abnormality. With the EMG, you're looking at the electrical activity in the muscle at the neuromuscular junction and the motor unit action potential. And ideally, you should have good recruitment, meaning that all the muscle fibers within the muscle at the motor within the motor unit activate when the nerve is stimulated. Waveform should be biphasic. There should be no signs of spontaneous activity, and amplitude should be within a normal range. This gives us an indication of whether or not there is voluntary muscle activity and whether or not the electrical activity in the muscle is normal or not. It can help you determine if synkinesis is present or not by having the patient perform activities of the opposing muscle group and seeing whether or not there's synkinesis in the muscle groups that should be silent during this opposing muscle activity. The best time to perform laryngeal EMG is no earlier than 4 weeks after the onset of vocal fold paralysis. And the reason for this is there are a lot of changes that are going on with the nerve in the first 4 weeks after onset of injury. And sometimes EMG can overestimate how bad the injury is, meaning that the EMG can tell you that the prognosis for recovery is poor when it may actually be good, because there's a lot of things that are absent in that first 4 weeks after the onset of paralysis that may come back after the 4 weeks has gone past. And then you also want to try to get the EMG before 6 months, because after 6 months, most of the reinnervation has happened. So what are the prognostic indicators for recovery? If there's presence of voluntary motor unit activity in that 4 weeks to 6 months period of time, then usually the nerve is going to recover. If there's presence of polyphasic waveforms, and polyphasic waveforms are an indication that either the nerve that was damaged has started to regenerate, and when it starts to regenerate, it starts initially with low amplitude polyphasic waveforms, or that a nearby motor unit that wasn't damaged. So if you have a nerve that was partially crushed and half the nerve is crushed and half the nerve is normal, the nearby nerve fibers may sprout over to those muscle fibers who had the damaged nerve and start to innervate them. And the large amplitude polyphasics indicates that some of this reinnervation or terminal branching has started to occur. Both of these are good prognostic indicators for return of function or return of good vocal mobility or vocal mobility. Poor prognostic indicators on the EMG are going to be the absence of voluntary motor unit activity, meaning that when you place the needle into the muscle, you don't get any waveforms, you don't see any recruitment at all, and you obviously can't find any evidence of amplitude or polyphasics. If there's synkinesis, meaning that the place the needle into the muscles that are abducting the and you ask the patient to do an adductory motion, and you see motion when the muscle should be silent, that is a sign of poor prognosis for recovery. Spontaneous activity in the setting of unilateral vocal fold paralysis, most studies are finding that it's neither a good nor a bad prognostic indicator of recovery. I think maybe 10 or 15 years ago, the teaching was that the presence of spontaneous activity is a sign of, is a poor indicator of recovery. But what we're seeing in patient studies is that spontaneous activity does not necessarily indicate poor prognostics or poor prognosis for recovery, but it definitely is a sign that the nerve is injured. Now, if you don't see spontaneous activity in a nerve that was acutely injured, then you may want to think that the patient actually had a cricoarytenoid joint issue and not a nerve injury, because usually an injured nerve should show some spontaneous activity at some point. So what is your algorithm for the evaluation of the patient with a unilateral vocal fold paralysis? One of the things you want to ask about initially is whether or not they're having any issues with dysphagia. Because if they're having issues with dysphagia and dysphonia, your treatment management is going to be different than if they're having issues only with dysphonia alone. If you do a modified barium, if they're complaining of dysphagia, I would do a modified barium swallow study. If they have no complaints of dysphagia at all, I don't typically order a modified barium swallow study at all. And then if your swallow study shows that they have no signs of aspiration, that'll kind of help you to just focus more on the voice issues and less on the swallowing issues, and maybe have them do a little bit of swallowing therapy with the speech pathologist. If they're showing signs of aspiration, and it's just aspiration alone, that's going to guide you one way, and Sandra's going to go over how that will guide you in terms of your management of the patient. If they're showing signs of aspiration, but then they also are showing signs that they have decreased sensation in the larynx, they have an asensate larynx, or they don't have a cough reflex at all. They have poor oral motor skills, they have poor bolus transit from the tongue base into the vallecula, they don't have good eversion of their epiglottis, they don't have good elevation of the larynx during the swallowing. All of those issues are going to still be there even if you medialize the vocal fold. And so medializing the vocal fold may be one thing that you choose to do for the patient, but then you likely are going to also want to do some other things in order to help with the swallowing. And I think Sandra's going to go over some of that also. In terms of when to get a CT scan versus an MRI scan. Usually if I'm thinking traumatic, iatrogenic, not skull-based, I'll get the CT scan. If I see cricoid joint dislocation, I'll address that. If I see a tumor, usually I'll address that. At some point I'll get an EMG. If the CAT scan doesn't really show any significant findings, and you don't really see anything else that you're concerned about, I'll get the EMG to look to see both which nerves are involved and what the prognosis for recovery is. If they have sudden or onset vocal paralysis that's not related to trauma and it's not related to surgery, usually I'll do an MRI and I'll get the blood test that we mentioned before. And then we're looking for metabolic issues, infectious or inflammatory issues, tumors or structural lesions. In addition to the MRI and labs, usually I'll do the EMG as well to help guide me with what the prognosis is for recovery. And once I know what the prognosis for recovery is, it'll help guide me in terms of how I want to approach the patient in terms of treatment. And Sandra, I'm going to punt over to you now to pick up.
All right, thank you so much, Ellen. That was really great. Let me get my slides up. Okay. All right, so I'll touch upon the management of unilateral vocal fold paralysis. And so we'll talk about approaches to diagnosis and management of unilateral vocal fold paralysis and take a look at some literature up to date on the treatment modalities that are available and their efficacy and when we do what. So basically, as Dr. Hamanaka touched upon, the larynx is important for trifold, and it's oftentimes considered a crossroads of sorts for airway protection, phonation, and respiration stabilization of the thorax. So it's important for us to consider that, especially when we're looking at patients that present with unilateral vocal fold paralysis, and prioritize the goals of treatment and set realistic expectations as to what we can do and provide for them as it pertains to their timing of the disease and mechanism of the injury that has occurred. So Dr. Roger Crumley out on in California discussed and coined this term vocal fold motion impairment, because oftentimes, like Dr. Hamanaka alluded to, there's multiple etiologies of this immobility or this impairment, and we don't know until we do a thorough workup what is the cause, and that's going to guide how we're going to manage it. And so neurologic manifestations are typically the ones that are most easily treated and addressed with interventions that we as laryngologists are able to provide. But what's interesting with this theory of vocal fold motion impairment is this discussion of laryngeal synkinesis. And this is a discussion that I have with practitioners outside of laryngology quite frequently, because this theory of laryngeal synkinesis helps us to drive treatment in the sense that providing early intervention helps to give the best outcomes for whatever intervention that we may implement, because of this aberrant reinnervation that we may get. That aberrant reinnervation of the vocal folds secondary after recurrent laryngeal nerve injury oftentimes provides this positioning and medialization of the vocal folds and maintains a tone that allows our best outcome for the treatments that we may employ. So vocal fold motion impairment is basically the catch-all, but for the sake of this talk, we've been focusing mostly on the paralysis. So I'll be using paralysis to discuss this further. So treatment of unilateral vocal fold paralysis. Whenever we're looking at patients, particularly inpatients, our goal is to make sure that their airway is safe. And, a lot of the consultations that we may receive as otolaryngologists may be unilateral vocal fold paralysis in patients that have significant aspiration. And to me, those are the patients that are priority, because we obviously want to avoid aspiration pneumonia in these probably already very ill and debilitated patients. And voice is a priority as well, particularly in professional voice users. So you want to make sure that those patients are optimized. And oftentimes the swallow particularly is multifactorial, like Dr. Himanaka discussed before. So you want to set realistic expectations in that regard too, because the treatment for unilateral vocal fold paralysis is at the level of the glottis, and that's it. So if they have issues with the upper esophageal sphincter or pharyngeal constriction or pharyngeal weaknesses or, hyolaryngeal weakness in manipulation of their swallow, the interventions at the level of the paralyzed vocal fold probably aren't going to treat that. So you may want to employ different modalities such as speech and swallow therapy in conjunction with a lot of the interventions that we may provide. So observation is an option, particularly just discuss with the patient what the risk, benefits, and alternatives to that are. And some people just opt to be observed because they don't have significant deficits in their speech or their swallowing. But sometimes based on our examination, if the cord is in an adequate position, it's medialized, they're getting good closure, they don't have a lot of glottic insufficiency, you may want to get voice therapy involved to mitigate any hyperfunction that may be occurring. And then surgery, obviously, if they have a significant deficit that's impacting their quality of life. So there's speech, in regards to speech therapy, it's kind of hard to quantify or qualify how effective this approach is in managing patients with vocal fold motion impairment, because there's so much variety in the content of the therapy that speech therapists provide, the timing, the duration, the frequency, and also the outcome measures are difficult to quantify and assess. But oftentimes, as laryngologists, we do our intervention as well as in conjunction with voice therapy, and that has been shown to improve outcomes in patients with unilateral vocal fold paralysis. So some patients do opt for just a trial of initial therapy, and they do get good benefit from it. And like I said, there is a place for those patients, and the particular patient population that would benefit from that is if they don't have a significant amount of glottic insufficiency that on a stroboscopic exam, they're getting good closure, they're getting decent, the cord is pretty medialized, and they have minimal complaints and no swallowing complaints. So moving on to injection laryngoplasty, this is probably one of the most common interventions that we do for patients with unilateral vocal fold paralysis, especially if it's a new onset apathic and things as such. So we are now in the office-based procedures, which is great because it allows the patient to not undergo general anesthesia and not really have a significant impact on their day-to-day functioning. They come in, they get the procedure, they go out, and it's done, and the voice is improved or the swallowing is improved immediately. So it's immediate gratification for everybody involved. Of the ones that are most commonly used, the ones that are FDA approved, which are the carboxymethylcellulose. This is mislabeled, I'm sorry. This is Prolarin Plus, a Prolarin gel, and then the CAHA is the Prolarin Plus. So those are the FDA approved injectates that are most commonly used. The carboxymethylcellulose is synthetic, but it does have a consistency similar to the more organic or superficial lamina propria consistency. So it doesn't have a significant impact on the vibratory properties of the vocal fold. And that usually lasts about, I tell patients 1 month, it can last about 2 to 3 months. Then you have the calcium hydroxyapatite, which is Prolarin Plus. That's also synthetic. And that lasts about a year, up to 2 years. Other injectables that we use that aren't FDA approved are your Restylane, which is hyaluronic acid, and that's a xenograft composed of extracellular matrix consistency and glycosaminoglycans as well. And that's commonly used off-label, lasts about 3 to 6 months. And then you have collagen that is oftentimes used, lasts about 3 to 4 months, but that's fallen out of favor a little bit because of its immunogenicity and its risk of a reaction to that particular drug. And the newest one that has come on the market is the Silk HA, which Dr. Carroll, I think he's in Boston, has been working on for quite some time. It's thought to be a porous silk and hyaluronic acid, and it just creates a scaffolding to allow for fibrosis and medialization of the vocal fold. That is as well FDA approved, but it just got on the market, I believe. And so I'm interested to see how that works as well as cost. And then fat is also another alternative, but a lot of patients don't really opt for fat. Different hands, it lasts variable amount of times. It's thought to be a lifelong injectable that's supposed to last quite a bit of time, but there's variable absorption. So you inject it and then, your initial medialization position may disintegrate over time because of the absorption, but also it requires different incision sites. So you have to harvest the fat, treat it, and inject it into the vocal fold. So in the right patient, again, that is a viable option, but not many people opt for that because of the two injection sites, the two surgical sites. So selection of injection laryngoplasty, as well as the material that is used, is oftentimes contingent upon the duration, as well as the cause of the vocal fold paralysis. And there's no single technique that's found to be superior regarding voice outcomes and even swallowing outcomes. So for me, I love Prolaryngel. I was trained with Prolaryngel. I use Prolaryngel for everything. Some people use Restylane, the HA. It lasts a little bit longer, so that is a benefit of the hyaluronic acid, but it's not FDA approved, so that makes me a little nervous about using it off-label when there is an off-label, on-label counter that is just as effective. And the calcium hydroxyapatite I use for appropriate patients that, don't want to undergo a medialization thyroplasty. They may have some predisposition to meningiomas or nasopharyngeal cancer. I don't know if the contralateral nerve is going to be affected in the future. So I would be a little hesitant to do a permanent implant on the contralateral, on the weakened vocal fold, while taking the contralateral cord into consideration of that being affected too. So I may do CAHA for those patients, or just patients that don't want to undergo general anesthesia or intraoperative procedure, and just want to get a quick injection in the office that lasts a little bit longer. And so things that are important is when considering injection laryngoplasty, particularly for in-office procedures, are the gauge of your needle. So you need a very, very small 28, 30 gauge needle so that you get an adequate injection and the injectate doesn't ooze out. The bend of your needle, the length of the needle, and even the temperature of the injectate itself. CAHA is very, very viscous. And so there's literature to show that if you warm it up, that it allows for it to be easily injected in office. And that's one of the reasons why at one point we weren't doing calcium, or not we, but many laryngologists shied away from doing calcium hydroxyapatite injections in the clinic, because you have to, number one, be very precise about the location of the injection. So this illustration on the far right of your screen shows that you want to make sure that you're getting it just lateral to the TA muscle and medializing it from the paraglottic space. You don't want to get in the superficial lamina propria, because that could have a significant impact, a detrimental impact on the voice. So you want to make sure you're medializing it from, near the paraglottic space. And so injecting that through that small needle, through the oropharynx, through a long Benjamin cannula, which you could see in figure A, that's the typical cannula that we're using, put you at risk for injecting into the wrong plane and having the patient have a really poor voice outcome. And so warming it up certainly helps. And now in-office calcium hydroxyapatite injections have become more favorable and more convenient for the patient. So with any injectate that you select, the keys to success are going to be patient preparation. So establishing rapport, being completely transparent about what is going to take place, how the procedure is going to happen, what they may feel, what they may encounter, the sensations that they may feel, very important to success. So you don't want to have any surprises. Adequate anesthetization. So typically we anesthetize through the nose with some 4% with Afrin to decongest as well. I also put some viscous 4% on my scope. And then if you have a working channel scope, you can drip lidocaine on the vocal folds. Otherwise, I might use a Benjamin cannula, the cannula that we saw before, and do transoral 4% topical lidocaine on the vocal folds. While they say E simultaneously, that E allows the vocal folds to be bathed with the 4% lidocaine, giving a good dense anesthetization. And then I may do benzocaine in the oral pharynx in order to numb the base of tongue as well as the soft palate as well. I need a skilled assistant to either be driving the scope or to assist you with the patient's comfortability and positioning. So 2 ways to approach transoral technique versus transnasal technique. I've been doing transnasal more frequently because I have more transnasal scopes, but you can do it with a rigid stroboscopic 70-degree scope transorally with a 2-hand approach through the oral cavity while the patient or your assistant is holding the tongue, or transnasal with a flex scope while you're holding the tongue and administrating the medication, the treatment through the oral cavity. We talked about the topical anesthesia, nasal anesthesia, as well as cricotracheal injection is another approach. So I topicalize transorally, but you could just do a simple cricotracheal injection with 4%. And then depending upon the patient's gag reflex and comfortability and comfortability, whatever works in the laryngologist's hands, you can do the transoral approach, which is most commonly done, but sometimes you have to switch or whatever works best for you. A cricothyroid approach is something that I've been doing more frequently lately, just because I find that if they have a strong gag, they're still going to gag if I do a thyrohyroid approach, which was described by Dr. Amin out of NYU. So you basically just have a double bend needle and you go through the thyrohyroid membrane and it pokes through just above the petiole of the epiglottis, and you maneuver your needle to just get into that paraglottic space as well. But you could do that from a cricothyroid approach just with the transnasal scope, and then you poke through from below and then you just laterally inject the vocal fold, and you get some pretty decent medialization. So this is a video of a transoral approach. Sorry, I don't want the music. Let me see if I can get the music off. This is the Benjamin cannula transorally with a transnasal scope going right lateral, and you want to be just at the halfway point of the mid membranous vocal fold. And for me, what is a good sign of a good injection is when you get that infrachordal bulge. That infrachordal bulge helps to reduce a significant amount of the glottic insufficiency. And pre-injection, I always talk to my patients about, look, you're not going to sound, like Adele. The goal of the injection is primarily to improve projection, and then as well as aspiration if they are having some aspiration. And the benefit of doing an awake injection is that you can see, okay, is the airway being compromised at all? Am I getting a good medialization of the vocal fold? And am I in an adequate plane? Am I not getting in the superficial lamina propria? And then immediately right there, you could test your injection out by having the patient speak, add more if necessary, or stop whenever you reach an optimal voice outcome. So back to the theory of synkinetic reinnervation, there is literature to show that patients that get injections sooner rather than later have better outcomes and may not require surgical intervention compared to those that wait. And oftentimes, it's not very well known that early intervention for these patients, at least in the general medical population, that early intervention for these patients provides significant improvement in their voice outcomes. So in a study done looking at 35 patients that had a vocal fold paralysis, 3 underwent late intervention, and late was about 6 to 12 months after the initial onset of their symptoms. And then 32 underwent earlier injection. And obviously the population is skewed quite a bit. However, the data does show that 100% of those that underwent late injection did need surgical intervention in the long run. And those that got earlier injections, 37% of them required surgery, but 62%, the majority, did not require further surgical intervention. And I've seen this. It's actually a pretty interesting phenomenon where you have a patient that has, within the 6 months of onset of symptoms, gets early injection, and they do get good medialization and adequate phonation, and then they don't have a deterioration in their voice quality after the injection. And those patients fare very well without any further intervention. So the key is early intervention for these patients in order to mitigate any further intervention or requiring any medialization thyroplasty in the future. And again, if you do an injection laryngoplasty on these patients, and if they do warrant further framework surgery, doing injections does not prevent you from having any framework surgery in the future if necessary. So back to calcium hydroxyapatite, there was a concern about awake injections, as I talked about before, because number one, it's a very viscous material and it lasts up to a year, up to 2 years even. So in patients that require intervention that is long-term, you want to consider awake calcium hydroxyapatite. But way before, many years ago, a few years ago, in my practice, I didn't do them awake in clinic because I was concerned that if it did get in the superficial lamina propria, they would be stuck with this terrible voice, or we'd have to take them back to the OR urgently and evacuate it. However, there is a culture that is shifting, and we are doing calcium hydroxyapatites more frequently in office. And this is just a paper supporting the fact that you can do long-term treatments for vocal fold paralysis in the office. There's a learning curve in the beginning. And interestingly, these patients had the cricothyroid approach, which I feel, for me, that the transoral approach works better. And I think that it just gives you more of a direct approach and better visualization of the proper landmarks for you to be injecting in the right area. So moving on to medialization thyroplasties, patients that have had vocal fold paralysis greater than 6 months. So there's a paper that came out by Lucian Salika out of Cornell that talks about how do we know when the vocal cords are going to come back and what is the timeline? And the answer is we really don't. So the general rule of thumb is anywhere between 6 to 12 months post diagnosis or onset of symptoms. That is when you can safely say that the patient probably won't get a return of their nerve function. As Dr. Himanaka alluded to before, you can perform a laryngeal EMG to kind of confirm that, and then do your treatment accordingly. So if there is evidence that the nerve is out and is not going to return, medialization thyroplasty is a reasonable option for patients as well. So this is just talking about the history of this procedure back in 1915 by Pear, who just essentially perforated and medialized a portion of the cartilage. And then Merman in 1952 discussed exposing the inner perichondrium of the vocal folds and just providing an implant to medialize the vocal folds in an adequate position. And then you have Sawashimi, who actually used a portion of the thyroid cartilage ala in inserting it into the inner perichondrium for medialization. And then the technique that is most widely known and utilized to date is Ashiki, who has graced us with the many thyroplasties, and his general approach is to make a thyrotomy on the lateral thyroid cartilage ala at the level of the vocal folds, preserving the inner chondrium and using whatever implant of choice to medialize the vocal folds to eliminate glottic insufficiency and improve phonation projection, as well as any dysphagia. So he, father of phonosurgery, Nobuhiko Ishiki out of Japan, treatment of vocal fold paralysis, atrophy, any issues with the vocal folds in relation to laryngeal trauma, pitch instability, and even spasmodic dysphonia. Dr. Ishiki has employed some thyroplasties that can help with the management of spasmodic dysphonia as well. So medialization thyroplasties are so the surgical treatment of choice for long-term rehab, particularly in regards to voice and swallowing that's caused by glottic insufficiency from vocal fold paralysis. And there are a number of implants that one could use. And again, preference, it's personal preference, what works best in your hand. Some of these have fallen out of favor, and we'll talk about why. But for me, I like Gore-Tex. I like that it's an inert material, it's pliable, I can manipulate it in the way that I want. It doesn't take a long time to fashion in the OR, and I get pretty good outcomes. And, you know, professional voice users, singers, and things as such, you know, if you're dealing with these patients that are very in tune with their own voice, you know, it's not only about projection. They're going to take into account the quality of their voice as well. And I feel that the Gore-Tex just doesn't affect the mucosal wave as much as like a more firm material like Silastic or Montgomery or even a Vocom would. And we'll talk about that as well. In conjunction with the medializations, you can also do Arytenoid Adduction. And then Laryngeal Reinnervation is another technique that can be used, not with medializations, but they can be used with other laryngoplasties as well. But this is just a picture showing basically the thyrotomy. You want to leave a little inferior strut of the thyroid cartilage, and usually the rule of thumb is 0.3 centimeters from the inferior border of the thyroid cartilage, and you want to mark out starting out maybe about a half a centimeter to a full centimeter posterior from the midline. I now drill, but you could make a rectangle box in order to enter the paraglottic space, preserving the inner perichondrium. And this is actually it looks like this is probably a fabricated Montgomery tube, Montgomery implant that just fits perfectly into the thyrotomy. And you see the medialization of the vocal fold in this diagram here. So Gore-Tex is my favorite. It's polytetrafluoroethylene. It was used initially for cardiac surgeries. It's semi-porous, has excellent tissue integration, minimal tissue inflammation, and low risk of extrusion. And if you have to do a revision, it's easily removable. It was first used by Dr. McCulloch, and he incorporated the pleating, which is challenging to do, and get perfect into the paraglottic space. It doesn't require any carving, and it's easy, limited edema intraoperatively, and you can adjust its height. So when you are making your window, you can tuck the implant into its appropriate position based on the acoustic feedback from the patient, because the medialization, as we know, is done under conscious sedation. The disadvantages are that it allows for shifting, and then you get easy compression of the implant so that it can reduce the voice quality quite easily. I haven't had that happen. You know, typically, in theory, the literature says that the surgery should last 10 years or more. You know, in older patients, you know, you may get more perceived longevity because of the fact that if they do have any glottic insufficiency from the paralysis as well as atrophy, you're kind of treating that as well. And you can do bilateral implants if warranted, if they do have a concomitant atrophy on the contralateral side that's significantly impacting them. But in younger patients, you know, they may get that atrophy as time goes on. And so that would be an indication for a possible reimplantation or considering other modalities to optimize their voice from a presbylaryngeal standpoint if warranted. Other implants that are used are Silastic. This you have to carve intraoperatively. So you fashion it within the paraglottic space and then interlock it within the window. Montgomery prostheses are prefabricated, so they come in various sizes, and that may speed up intraoperative time compared to the silastic. The silastic, and it also is made of silastic, so it's a more inert and less reactive material. There are instruments that allow you to measure and create the window more precise. And then with the silastic, because it's fixed in that window, there's low risk of migration in comparison to the Gore-Tex. Again, the disadvantages are it's time consuming. Again, there's significant impact on the mucosal wave, and it is expensive. If the prosthesis doesn't fit, you're going to take it out, and then you're going to have to try another prosthesis. So that drives up costs quite quickly. And then because it is a fixed a block, in essence, you can't control for overcorrection anteriorly. And then you might not be able to control or completely close a posterior glottic gap. So on these instances, you may need to take into account, and even with the Gore-Tex, you might need to take into account an arytenoid adduction in conjunction with these particular procedures. And when you're doing the arytenoid adduction, then you can't really take into consideration acoustic feedback because you're going to have to do the procedure under general anesthesia. The Vocom is an older implant that was used, and it was favorable because it was biocompatible as well as for its durability. You get instruments to measure the window, subtle adjustments that are allowed for more precision, that are better than with the Montgomery implant. And again, there's low risk of migration because it locks in. It osseointegrates. So I actually have a patient that I just saw today that has a Vocom implant that we're going to have to try and figure out how to explant, because or do a superimposed implant or implant the contralateral side. Because of the osseointegration, it may be impossible to remove the implant. So that's a major disadvantage. The one that I don't think it's commonly used is a titanium implant. And again, it's stiff, and it has a significant impact on the mucosal wave as well. But it is durable and biocompatible, and prefabricated, no special instruments like you need with the Vocom, and saves time in that regard. So what do you use? Which one is better? There's this paper that actually just talks about silicone and Gore-Tex. And so this just speaks towards the efficacy of Gore-Tex being less invasive and requiring a shorter surgical time. You don't have to fabricate it intraoperatively. There's another paper that I don't think I put on this PowerPoint slide that actually does touch upon the mucosal wave. And there's literature to show that the Gore-Tex does have more better outcomes in regards to subjective voice because of the mucosal wave that is not significantly impacted as compared to its other implant counterparts. Which one is better? When do you do CAHA versus, medialization thyroplasty for patients that need long-term interventions? So the meta-analysis looks at the evidence of generalization for voice outcomes, and they are saying here that they reported equivalent voice outcomes in VHI as well as maximum phonation time across injection laryngoplasties with calcium hydroxyapatite in comparison to medialization thyroplasties for individuals for unilateral vocal fold paralysis. So, at that point, you need to look at the patient on a case-by-case basis. Like I said, if there's a patient that has nasopharyngeal disease or malignancy and you don't know if the other side is going to be impacted, you may want to just consider starting off with a CAHA for longer term, but not permanent intervention. And then for patients that have a definitive vocal fold paralysis that is either known to be iatrogenic, and there's no chance of the nerve recurring, or they're outside of the window for the chance of recurrence of function, then you want to consider the medialization thyroplasty. But the outcomes are proven to be equivalent. So Excellent outcomes can be attained with the use of a variety of implants. Sorry. It depends which one works in your hands. I love Gore-Tex. I know people that love the Montgomery implant as well. I have patients that have the Montgomery implant that are singers that do say they do notice a difference in their vocal quality, that their projection is great, but they have a lot of pinch instability or just have a lot of issues with maintaining their singing abilities because of the limitations they attribute to the less pliable implants. So special scenarios, if a patient has a vertical short thyroid cartilage, which you could glean preoperatively on physical exam, you may have some difficulty obtaining that inferior strut that you would need for a Montgomery or a Vocom implant. So you may want to consider a Gore-Tex because you can not really have the stress of focusing on, having this important inferior strut, and you could just dissect the inner perichondrium and place the implant in whatever position that it needs to be, regardless of the placement of your window. And then your hand carved silastic can also allow you to adjust the vertical height as well. In patients that are undergoing revision thyroplasty surgery, the pre-existing window is an advantage for a patient that's going to go, if you were considering Gore-Tex, but if you are going to consider using a prefabricated implant, it's not going to fare well for those particular patients. So for revisions, you may want to consider either tucking a Gore-Tex implant medial to the current implant, which is challenging. But the issue with that is, and I've seen it, where if you do an explant, there's a fibrous capsule that forms, and that fibrous capsule is going to be difficult to fill. So you're going to be trying to implant a large defect in a large cavity, and Gore-Tex alone may not be optimal. And then you also may want to consider silastic or even an Arytenoid Adduction for those particular patients. So this is a medialization that I did for a patient that had what looked like vocal fold paralysis congenital that was never managed since birth, and he's 20 years old. So that was just creation of the thyroid cartilage window. Intraoperatively, you want to do a laryngoscopy after you create your window to ensure that there is no tear, so you don't get extrusion. And you also want to palpate the inner perichondrium to make sure that your placement would be sufficient. This is just cutting out the Gore-Tex implant. You can see it's about 0.4 millimeters thin. You make it about 0.4 to 0.5 millimeters wide, and then you place the implant into the thyroid cartilage and try and pleat it in as best as possible. It's a moving target.
There you go. Does that feel better? It's deeper. Taxi.
Taxi. There you go. He's got improvement in phonation. And he actually had a little bit of hyperfunction too. So preoperatively, he had a lot of plica ventricular, so he's engaging his false folds. So we were able to kind of implant him. I injected him before to see if he would get better with eliminating that false fold contact, and he did. So we decided to move forward with the medialization thyroplasty, and you can see that his hyperfunction has improved as well. And he did get voice therapy for that too. So a lot of our patients that we are looking for medialization thyroplasty have undergone radiation therapy. So the question is, would they benefit from medialization thyroplasty? Which material should we use? There's a paper by Ekbom that he likes the Montgomery or the silastic better, and Rossow from Miami actually likes Gore-Tex better. So they both studied their respective favorable medialization thyroplasty implants, and Dr. Rossow actually found that there's minimal complications in patients that underwent radiation with implants with Gore-Tex for medialization thyroplasty. And Ekbom compared Montgomery silastic and found that the silastic was actually fared better in regards to postoperative complications in patients that had radiation therapy. So we really don't know. I use the Gore-Tex. I think the most important thing to do in these particular patients is to consider the preserving the outer perichondrium. So when you, and not making such a large thyroidotomy or thyroid cartilage window, so that you maintain and preserve the vasculature to the thyroid ala, so they don't get any chondronecrosis. And then you want to, the ideal placement, not just for post-radiation patients, is to place the implant posteriorly and laterally to prevent impingement of the Ranke space. I do posteriorly and inferiorly and get pretty good outcomes with that. But again, the acoustic feedback is going to be important. So Dr. Ishiki talked about arytenoid adduction as well. He created the procedure modified by Dr. Gail Woodson. And basically it's a suture that you place around the muscular process and tied to the thyroid lamina. And it mimics the function of the TALCA complex. So you want to move and rotate the the arytenoid medial and inferior in order to position it in its physiologic position. And you get adequate closure of any posterior glottic gap. But it's also important, if you notice patients have vertical height mismatch, it can correct that as well. So, some people do this in conjunction with the medialization thyroplasty, but I think the acoustic feedback intraoperatively for the medialization is important. So if this were warranted, I would stage it and see what the outcome is with the medialization thyroplasty alone, and then consider doing an adduction if they had a persistent glottic gap postoperatively, and if there was a height mismatch that was visualized. And so this is just an image showing, this is the lateralization posteriorly when they close, when the vocal folds adduct, you would still see a gap under those circumstances. But then when you position and rotate medially and inferiorly, then that is reduced. So another intervention that is pretty neat is the Laryngeal Reintervention option. Typically, these patients are going to have had an intraoperative complication or an issue where the vocal fold, the recurrent laryngeal nerve, may have had to be transected for cancer or for whatever reason. And if identified intraoperatively, it's recommended that these patients undergo reinnervation at that time. There are many techniques. The neuromuscular pedicle is one. The most common used one is the nerve-to-nerve anastomosis, whether it's primary or ANSA. You can even use 12, or nerve to muscle, looking at ANSA to the TA muscle, so direct innervation of the TA muscle by the ANSA. You may combine, and it's recommended that you combine any reinnervation with an injection laryngoplasty that's temporary, because the effects are not immediate. And so this is just an image displaying the ANSA to the recurrent laryngeal nerve. And then you have the neuromuscular pedicle, which is going to require a thyrotomy to place it near the lateral cricothyroid muscle, helping with better voice quality and adduction. And then you can do a direct implantation into the thyroid muscle. Again, advantages, it restores the bulk. You may not get complete mobility, but it's the same theory of this synkinetic reinnervation, that you're going to get good muscle tone, and that's going to help with the phonation. You can get improved positioning of the LCA, the inner and the PCA contraction. It eliminates the dysphonia due to synkinesis. And again, if you need to do further static methods, for whatever reason the innervation hasn't worked or did not work, you can still do that in the future. But you do need an intact donor nerve and a recurrent laryngeal nerve stump at the functioning proximal nerve, and it does have increased time to vocal improvement. So that's why we recommend doing the injection laryngoplasty in conjunction with it, and it is more costly. So several studies touching upon laryngeal reinnervation, there was no significant difference in aerodynamic measures or perceptual ratings between patients that underwent arytenoid adduction with recurrent laryngeal nerve anastomosis versus arytenoid adduction alone, which is interesting. 28% of patients had voice deterioration at 6 to 24 months after medialization versus 4% in 24 months in surgical medialization with reinnervation, which makes sense, right? Because you're expecting there may be some issues with surgical medialization post-op in the long term. However, once the once the reinnervation takes and the muscle tone is improved after 24 months, that's when you're really going to see an improvement in those particular patients. In another study, there was no difference in perceptual rating in blinded speech pathologists looking at the GRBAS or the VRQOL scores. And interestingly, patients that were younger had better scores compared to after reinnervation compared to medialization in comparison to patients that were greater than 52 years old. So, you know, the neuroplasticity of younger patients is known and is evident in these particular studies. So younger patients definitely fare well, and pediatric patients certainly do fare well with reinnervation compared to adults. And after 36 months, patients with reinnervation voice improvements remain stable compared to patients that underwent injection laryngoplasty, which is to be expected, which deteriorated over time. So take home is immediate intra-op RLN reinnervation via primary anastomosis or ANSA should be done if injured during surgical procedures, whatever the intervention is, thyroids, parathyroids, you should consider doing the reinnervation there on the spot, and also doing concomitant injection laryngoplasty for the patient in order to have best outcomes. Down the line, I haven't found any literature discussing reinnervation, you know, for patients that have had outside of intra-op interventions or, you know, longer than 4 days. There was one paper that talked about vocal fold paralysis 4 days afterwards doing a reinnervation procedures, and those patients fare well. But I would be curious to see how patients are doing if, you know, you see them a month after whatever thyroidectomy that was done by an outside physician and you take them for a reinnervation, how they would do. The jury's still out on that, but if anybody knows, I would love to chat about that too. So the Korean Society of Laryngology actually just recently came out with guidelines for the management of unilateral vocal fold paralysis. And so it's pretty much what we discussed. So if based on what your expectations of recovery are and your laryngeal EMG findings, your causes for vocal fold paralysis, as well as the duration, if you suspect that it's probably transient, then you can consider voice therapy. If there is any evidence of aspiration, it may push you more towards injection or, you know, some sort of intervention. But if they are having good compensated voice with minimal aspiration, then you could do voice therapy. I probably wouldn't inject those patients, or you could just wait and see, patient preference. If they have uncompensated voice as well as or aspiration, then you would want to probably just inject them while we're waiting to see if the vocal fold function is coming back or not. And you can repeat the injection. If you're doing the carboxymethylcellulose, it lasts about a month, and you're, you know, 1 month out from there, whatever incident of vocal fold paralysis, I would continue to inject them when the injection wore off until we're at the 6 to 12 month mark where we could talk about more permanence. If there isn't spontaneous recovery and you're reaching that 6 to 12 month mark, then you want to have a talk with your patients about more permanent procedures. So you want to talk about immediate reinnervation procedures, which doesn't mark with the 6 to 12 month mark. That would be immediate intra-op during the surgery. But if they have compensated voice and no aspiration, you may consider voice therapy, surgical medialization if they have, you know, glottic insufficiency or they can't talk for long periods of time, air wasting. But if they are permanent and uncompensated, then you would be more apt to move forward and skip voice therapy, maybe do voice therapy afterwards, but you want to do a surgical medialization procedure or a longer acting injection, plus or minus arytenoid adduction. So other techniques that you can employ, and they've talked about this nimodipine for facial nerve, but the literature is in favor of using nimodipine for the proper patient. So I have patients that have been interested in nimodipine, but unfortunately their blood pressure is already low at baseline. So I haven't had an opportunity to start it on them, but it is promising that this calcium channel blocker could improve functional recovery after peripheral nerve injury, as well as in conjunction with reinnervation. And the mechanism of action is just by blocking the intracellular influx of calcium within the ions and improving growth cones on the injured nerve and promoting axonal regeneration. But again, you need to take into consideration whether or not, they will have significant side effects as a result. And I would probably consider employing the primary care in order to provide optimal outcomes for these patients with minimizing side effects or adverse effects. Other novel techniques, gene therapy, something to be considered, as well as aberrant nerve regeneration and innervation with neurotropic factors. And that these typically require direct implantation into the site of injury. And so the jury is still out, but it does look like it may be promising, especially now that we're getting savvy with our gene therapy in other areas as well. And so there is benefit to immediate intraoperative laryngeal nerve graft, and we're still trying to investigate whether or not outside of intraoperative laryngeal nerve graft, whether or not there would be some benefit for that for patients with neurography and anastomosis in the future. The sooner the intervention in addressing unilateral vocal fold paralysis, the better the outcome. And I think that's key, in the proper patient with the appropriate workup and ruling out the appropriate things like Dr. Himanaka mentioned, whether or not you think the nerve is going to come back, there's really no reason to watch and wait other than if they're medialized in the appropriate position and they're doing well and they're satisfied with their voice and there's no evidence of significant glottic insufficiency. If they are just remotely in the paramedian position and their air wasting or their voice and the phonation is significantly impacted, and especially if they have swallowing issues, I would inject them quicker than later. Treatments are contingent upon symptomatology, as well as the mechanism of impairment. And longer term treatments are also selected on a case-by-case basis. So there remains to be a lot that needs to be determined in studying unilateral vocal fold paralysis treatment outcomes, and uniform modalities at assessments are needed in order to do so. So that's Thank you so much for your time and attention. And I guess Dr. Himanaka and I will take questions now.